Basics of free flap surgery. We all know about the reconstructive ladder. Use simpler things to reconstruct and then go to the higher. Free flaps are at the highest point of this ladder. So why use them? Well, you might be faced with a defect that cannot be reconstructed by regional or local flaps. What are such problems? One, it's such a large defect and nearby you don't have any available local flap or regional flap which can reach there and cover. Or it may not be adequate. Flap is available, but then there are other issues of the pedicle in it. It's an irradiated area, or you need to reconstruct various different components in the flap that may not be possible with just this available regional flap, and it may not be acceptable to have such a donor defect. Going to what are the advantages of this free flap? One, we can get a specialized tissue. What are the examples? When you need to obliterate a space, you can get a muscle, you can include a vastus lateralis along with the anterolateral thigh flap. Then you can do it in one stage. Then you have a choice of donor. Here in particular, again, let me speak about few specialized tissues which can be available. You have the vascularized bone graft, or you have enteral conduits, then composite reconstructions, mandible and floor of mouth, then reconstructing something that is lost like a finger, free toe flap. Then if you have to do reconstruction of the penis, these are places where you can use a free flap, which is most apt. Then you can even tailor the flap. You can, depending on the characteristics of the defect, the size. You can also have chimeric flaps. Then what are the patient factors? Age is not such an important factor. However, extreme elderly patient can have a problem with post-operative medical complications. Then smoking has to be stopped at least 4 weeks before any free flap reconstruction wherever possible. But then smoking does not affect the anastomosis. Instead, smoking rather affects wound healing, particularly in the donor site or even at the flap and bed interface. Another problem is alcohol withdrawal. They are known to have flap complications and even medical complications. Next is obesity. If the patient is having a high BMI, obese, or even overweight, you have a clear problem with the bleeding and hematoma formation. Next is diabetes. Diabetics have slightly increased rate of intraoperative and post-operative complications. However, for anastomotic complications, no. But rather you should see that the vessels may have atherosclerosis, atherosclerotic plaques. Then liver disease. It is not directly proportional to the severity of the disease, but then patient can have intraoperative and postoperative complications. Immunosuppression is very important because we get so many of such patients. If a patient is on prednisolone, is immunosuppressed, we can have thrombotic complications, flap loss. Then recipient side problems. Well, post-trauma wound need a good debridement. There should not be any debris or devitalized tissue or even any vegetation which can later cause problems. Once covered with a flap, if the debridement was not good, bound to have problems. Then in case of irradiated wound, preferable to keep the anastomosis away from this irradiated site. Then infected, there should not be any infection. Good debridement is required. No compromise. Then pedal pulses. Sometimes we may see both pulses dorsalis pedes, posterior tibial may not be palpable. Do a Doppler, handheld Doppler, and see. Some patients may require an arterial angiography before planning. Even then, frankly, we may have to go for an end-to-side anastomosis. All these planning has to be done beforehand and not surprised on the table. Choice of flap. Again, is free flap really necessary? Well, a very elderly patient with debilitating cancer, free flap surgery is too big. Well, a resection of the tumor covered with regional flaps more apt. Then there can be donor site problems which may not be acceptable. One is the cosmesis. Second, how we are closing it, whether it's possible to directly close it into the skin graft. Third, there can be hernias. These are few examples that we ought to think before deciding which is our donor site. Then length of the pedicle may not have sufficient length of pedicle. For that reason, we have to first examine the recipient area, expose the recipient vessels, skeletonize them, and then when we are doing the flap harvest, we might also require to have painted and draped additional area from where vein graft may be required for interposition. Then, as I already said about the components needed, expertise and experience. There has to be very good expertise of doing microvascular surgery, and experience is even more important. We cannot use fancy flaps. Those flaps which have stood the test of time should be used. And also, surgeon's experience with them. Anesthesia. Discuss with the anesthetist the type of anesthesia that is required, whether neuromuscular blockade is required, then need to maintain the sympathetic tone so that there is no vasospasm. Another important thing is the position. You may have two teams operating at a time. So all this has to be discussed in detail with the anesthetist. Antibiotic prophylaxis, the anticoagulation, then equipment. Microsurgical instruments, loop, microscope. It is advisable to do the microvascular dissections under the microscope and also the anastomosis. However, a lot of surgeons do prefer to do it under loop. Then heparin saline to clear the debris, and then of course clamps.